we are recording, so everyone look their best. No. So today's session, as all the sessions, will be recorded, and I'm going to make sure all of those are uploaded to our YouTube playlist with these recordings, and that link will be available to you via Box. And I should have sent out that link to all of you. You should have received it. If you don't have it, feel free to let me know at this Yale Survivorship Echo email, and just shoot me an email and I'll make sure you have it. All of that will go out in a reminder email after today's session. The breakdown for today's session is as follows. We're going to start with introductions, have a presentation after that about Survivorship 101, some of the basics, some time for discussion, questions and answers, and some quick reminders at the end. Again, this is supposed to be a discussion. I encourage all of you, raise your hand either on the Zoom function or just wave at us or type into the chat and let us know if you have a question or comment. We're hoping during the presentation to save everything for the end, just in the interest of time today. We're going to be doing some introductions, but definitely come with questions, and I hope you have some prepared already. So I'm going to turn it back over to Scott, and we'll start with introductions.
All right, great. Thank you, Jevin. So before the time of social distancing, we were allowed to take this picture, and this is our team, of which we are very proud of. And Dr. Sant is going to get into a little bit of the history of how this clinic came to be and how we get to have so many amazing people be a part of this team. But from my left to right, Maura, our dietitian, myself, Angelique Williams, who we affectionately call Kiki, is our admin. Angela, our social worker, Jevin, our physician's assistant, and Dr. Tara Sampt, who is our medical director. That is our team. I also do want to point out Ashley. Ashley is somewhere on the call here. She's really been the firecracker to get us started with Echo, really kind of brought this whole idea of Echo to us here at Yale Cancer Center and Smilow Cancer Hospital. And so the whole idea of having the hub, so to speak, of centers of excellence and being able to disseminate that information out to spokes. So really teaching the teachers about best practices in a variety of different ways. And so, so we will be considered the hub for these Echo sessions, and you guys are all of our spokes. But obviously, the wheel is strengthened by the strength of the spokes. Full disclosure, I'm a cyclist, so I like a nice aerodynamic wheel with nice strong spokes so that I can go really fast when I'm riding. So you guys are really going to make these sessions everything that they will be. So thank you for being here. So moving on, we really want to get a sense of who you are. Again, there are some familiar faces, familiar names that are joining us today, but there's some new faces and names as well, which I think is really, really exciting. And so we want to take the next couple of minutes for everybody to say who you are, what you're doing with regards to oncology care, especially in 2020. What was your oncology care looking like prior to March, and what it's looking like now? And then also, we want to get a sense from you, why are you joining us? What do you hope to get out of these Echo sessions? And so I am gonna call people out and kind of put you on the spot for a minute. And I know everybody's screen looks a little bit differently, so I am just going to go down my list that I have in front of me. So I'm gonna ask Elizabeth and Amy from Northern Lights. If you guys can wave and point yourselves out to everybody. Let us know, what you do up there at Northern Light Health, and what's your role in oncology care, And then, again, what do you hope to get out of these echo sessions?
Hi, I'm Elizabeth. Can you hear me through the mask?
Yes.
Yes.
Perfect. So I am a general internist. I've been working to support a rural outreach cancer clinic that is owned, I guess, by Northern Light for several years. And then in the fall, I was hired full-time to come on site to help the organization regarding survivorship. So supporting people in their survivorship phase of care. So I don't have a program. You're looking kind of at the program. And then, of course, I had all sorts of great educational things planned and networking, et cetera, and all that got derailed, if you will. So I'm seeing virtually some patients. We're starting with breast cancer survivors, and we're doing it in a very informal way. But I stumbled upon your model, and I think it's fantastic. So I'm really interested in learning more about the multidisciplinary model. And I'll pass it on to Amy, who does lymphedema here for us on site, because she is also very interested, and she's a physical therapist. So,
hi, thanks for having me. I'm Amy St. Peter. I've been a physical therapist for, it's my 24th year, and specifically doing lymphedema and breast cancer related ailments, if you will, for the past 6 years. So Elizabeth stopped me and we got chatting one day because my role has changed with this whole COVID thing. I've been screening patients at the door because I can't see patients, hoping to start next week seeing a limited amount, especially those that need me. But we got to talking and she was telling me about it, and it just sounds really interesting, something I definitely want to be involved with. So thank you.
Well, and that's great. That's great that you guys are working together and you guys are collaborating. And that's really what this is all about, is creating relationships and collaborating across disciplines to provide this multidisciplinary care for our survivors. So that's great. So awesome. All right, Erica and Kathleen from Middlesex Hospital. You guys want to go ahead and tell us what you're up to and what you're hoping to get out of the echo sessions?
So I'm Erica Brault. I have been involved with oncology rehab for about 7 years. We here at Middlesex, we have what we call our core team, which is called Center for Oncology Rehab Excellence. So this team has been in place for about 10 years. And we collaborate with the Cancer Center here at Middlesex Health. And I always felt like I wanted to reach out a little bit more to other people, whether it's academic folks or clinicians, to gain more perspective on treating oncology patients. So COVID has definitely changed how we do things here, but we have been able to see a limited number of patients maintaining social distancing and the like. But definitely we would like to get up and running a little bit more, and then hopefully gaining a lot from talking to other folks like yourselves. So thanks very much for having us here. So Kathy, I don't know if there's anything you wanted to add to that.
No, I'm good. I think you spoke well for both of us. I'm a physical therapist also. I work in a satellite clinic in Marlborough, Connecticut. So we see patients who have a history of cancer and are cancer survivors. And having gone to a few oncology sessions at combined sections last year, and then speaking to my patients about what I learned, I found that there was a deficit of education that they had received following their treatment. So I jumped on board with that and hoping to improve that.
Yeah, that's Kathy, you bring up a good point, and I think that's one of the big pushes that that we're trying to do across the physical therapy field, is to get more physical therapists involved, and to educate PTs so that we can educate the patients. So now we have board certification, which is a great way to get clinicians up to that next level of treating patients. There's more and more of these oncology residencies that are popping up around the country, so that the new grads kind of have that transition year to give them the experience before they head out into full-time patient care. So we're getting there. We are getting some traction with everything. So that is really exciting. But you're right. And again, that just goes back to why we're doing this here. Just to show where does the physical therapist role fall in this multidisciplinary approach. Because yes, we need to be able to educate the patient, but we also can't operate in our own silos either. And the best care is collaborative care. So thank you guys for joining us. Michelle, tell us a little about what's going on in Toledo.
Well, I'm Michelle Masterson, and I've been in academics for 30 years probably. And I retired as the program director of our DPT program. And 6 months later was rehired as a part-time director for our School for Interprofessional Education. So now I'm involved in all the interprofessional piece. And during that time, I was diagnosed with breast cancer. And so I went through our University of Toledo Cancer Center. We have a comprehensive cancer center, the physicians, nurse practitioners, everybody does real well with collaborative care. And then across the parking lot is our oncology rehab team, and they're really great and wonderful too. But there wasn't a lot of integration between the two. They knew of each other, they made the referrals, but we weren't as involved. And so I got involved because my care was fine, but I'm like, why am I not getting recommended for PT? Why am I not getting baseline measurements? Why am I not getting pre-op referrals to be able to get that education that I would need for all that? So I talked to my doctors, I talked to the team, I talked to the rehab team, and we are now really getting more collaborative care. We're attending tumor board meetings. We're in the process of working out some more standardized referrals and some algorithms for how we can all work together. But we have two nurse practitioners that run the survivorship program. And they are really excited. They're wearing so many hats, and they just would love to have some more interprofessional, interdisciplinary teamwork with the survivorship program. So I was at CSM and I attended your presentation. I thought, this is perfect, because I have everyone buying in and wanting to do it, but it's like, okay, how do we get started? Mm-hmm. So it was perfect timing. And then when this opportunity with the ECHO came about, I told the nurse practitioners, let me go and I'll kind of gather some information, and I may have, they may come in on some of these weekly sessions. But so our hope is we're more involved now with the meetings and getting to know each other. But I think if we can really get involved in helping that survivorship program, and then maybe work our way back a little bit and get more involved in the clinical and the acute care and the pre-op and the active treatment phases, I think it would really be a good overall outcome. So
wow, that's all amazing. And how are you?
I'm fine. So I was diagnosed in 2018. So this July will be 2 years. I had a mastectomy, chemo, radiation. I'm on the letrozole now. So I've been little over a year on letrozole. So 4 more years of that. But I had my survivorship meeting with the nurse practitioner. I was like, this is it. I mean, this is great information, but I was really expecting, more people like your team. Mm-hmm. So I was like, okay, we can do this.
Mm-hmm.
So
yes, we can do this, and we will do this. So, yep. So thank you for everything that you're doing. And you're right, you carry some very unique perspectives that I think goes a long way. So
as a physical therapist, my background's really more the neuro, and I was really involved with Parkinson's clinic and things. So I've kind of shifted gears and putting my efforts more into the cancer oncology rehab, not so much as a practitioner, but a behind the scenes administrator. And I've got a team now of PTs, OTs that they've been doing oncology care. I'm just trying to help them get coordinated and integrated more with the physicians and the team in the cancer center. So
Yeah, absolutely. And that's been one of the big things that I've learned is that, you have your champions, Dr. Sampton and Jevin are two of my big champions, when it comes to referrals and then, for them to be able to also, do their own networking with their colleagues, that's where we get more of those referrals and everything. So,
Yep.
I'm so, I'm so blessed to have them, as my colleagues and my friends to be able to, help with those referrals, outside of the survivorship clinic, as far as the outpatient stuff is concerned. So
Yep.
absolutely.
Very good. Thanks.
Sarah, tell us what's going on up in Torrington.
Can you hear me now?
Yes.
Okay. So basically, I was a nurse down at Milo in New Haven for about 5 years while I was getting my master's, and I've been up in Torrington as their nurse practitioner for the past 4 years. And I'm brand new to survivorship. I guess the nurse practitioner here used to have a role in it, and now that I've been here a bit, it would be nice for me to get involved. I typically see a lot of the treatment patients, and I'll work like collaboratively with Dr. Brandt, for her breast cancer patients while they're actively getting treatment. And then I kind of don't see them anymore. So it'd be nice to be involved, seeing people, people doing well. We have a dietitian that is here a few days a week and a social worker. Pre-COVID, they were here, and hopefully sooner than later, they'll be actively back in the office. So it would be nice, to try to get some of those resources, like you guys are doing, so to make it more of a collaborative, rather than, here is your survivorship and we kind of just go through it. If the dietitian can come in, that's their specialty, so they have a lot more to offer than I do. So I'm just interested, just because I'm brand new, to see how you guys are functioning. I know Javin did a Zoom meeting with me before this and was kind to show me how you get the plans built, but it's interesting to see how you're doing it collaboratively. So I'm looking forward to this.
Yeah, well, that's great. And, that's great that you've, kind of taken over the reins up there in Torrington. And definitely, when we do our next session, affectionately referred to as the nuts and bolts of putting together a survivorship program, that's what we're going to be talking about, is how do you actually physically get the bodies together, and that sort of thing. And, how do you get everybody in one room, more or less, to be able to do that collaborative approach? So that is definitely forthcoming.
Great.
Ellen, who I just got a chance to meet a couple of weeks ago. I know you told me a little bit about what's going on, but for the benefit of the rest of the team and everybody who's here, tell us a little bit about what your role is at Quinnipiac University.
I'm a professor in the PT program, and our students have a capstone project every graduating year. They present a capstone research project. 2 years, I had been diagnosed in November of 17 with breast cancer. When I was discharged, my oncologist said, "Hey, Ellen, I think you need a purpose in life." He was frustrated at St. Francis Hospital in Hartford that he felt like a lot of his patients, as soon as they're admitted to the hospital, just kind of languish in bed, that they are put on bed alarms unnecessarily and aren't allowed to really exercise much. So he really said, is there any way you could try and get some sort of mobility program going? And frankly, this is way out of my comfort zone in terms of, designing anything like this, but we were going to start, the students and I, with a survey to both the PTs and the nurses on the oncology floor about what some of the limitations were in terms of mobilizing patients. Well, of course, COVID hit, and I've been struggling to get the nurses' surveys back. But Scott has helped us quite a bit and gave us some ideas about how to pursue and maybe just work with nursing to just provide them with educational, I don't know, webinars or even just literature And so I'm here to learn and pick up anything that I could to apply to this project, but also I think going forward, it will help educate me quite a bit too, is I think about incorporating my students who are going out on clinical experiences in oncology units.
Yeah, it was great to connect with you and your students, and you're right, like the earlier that we can mobilize our patients, the better off they're going to be. And if that message is consistent, throughout the system, then it's more likely to happen. So hopefully, we can continue to give you, some good, good tidbits moving forward, and continue to help collaborate with you guys. And Heather, down in Greenwich, how are you doing down there?
Good, thanks. Alone in my very large office. Nobody else is here.
Mm-hmm.
Good. So I actually am an occupational therapist by trade. I just recently, right in the midst of COVID, changed roles at the hospital from therapist to our oncology survivorship coordinator down here at Greenwich. So it's been a little bit of a good thing that COVID happened when it did, because I was having to stop treating patients anyway. So this sort of came in at a good time. It's a positive light of something good that happened. But now I will be coordinating the program. Prior to COVID, I was only seeing oncology patients. We have a very strong cancer rehab program that we started. I started here 20 years ago and got my lymphedema certification 6 months later, and have been started doing lymphedema treatment, and that sort of dominoed into myofascial release and everything post breast cancer. And then just seeing the need for it, and working with one of the breast surgeons, got together and started getting patients in before their surgeries to do evaluations on them, and doing, we have an LDEX, doing our LDEX measures before. We were STAR certified when it came out, so we held on to that until they went away. And so we trained, we had 20 people on staff between therapists, social worker, nutritionist, all that, all STAR certified, and really tried to get this comprehensive survivorship program going. And really what it turned out to be was this really comprehensive rehab program and the cancer center. So somebody had said, the cancer center was across the street. Well, they were across the street, and we just felt this huge divide. And it was like, how do we, why isn't it so automatic for them to just refer the patients? And it just, for years and years, we've been battling this. And I finally, we had a lot of administrative changes, so we get it going and it be working, and we'd have all these patients coming in, and then we'd have an administrative change and it would just fall by the wayside. So I think now that we've got all the players in place and this role in place here, and connected with Smilo, and having you guys up there will just help strengthen our program and just get it all cohesive, and really get the patients in from day one and follow them all the way through until they're done.
Yeah, absolutely. And yeah, you're just down the road, and so we need to continue to collaborate. And all your years of clinical experience is just going to I think benefit the program, because what these patients need, and you see not just their physical needs, but their psychosocial needs, and their everything else that they need as far as long-term care. And so you have that benefit, and so you're an amazing resource for these patients. So thank you for taking on this role.
Yeah.
You got this.
I'm excited. I'm excited.
So good. So we're glad you're all here. And so we want to take the rest of the time to kind of set the table for you guys as far as survivorship care especially Survivorship Care 2020. And then over the next several sessions, we will be getting more into the nitty gritty. Again, we'll get into the actual nuts and bolts of, how do we actually do the collaboration? How do we actually get all of these providers into one room, into one space? At least we were able to be in one space. And even now, I mean, we are still working together, even though it's virtual. So how do you get us all on the same call to be able to do this? And then we're going to really go through, how each of us kind of brings our professional backgrounds to address certain long-term side effects that we see in our cancer survivors. So we'll get into that more. So moving forward, if we go back to sharing our screen now, Jevin, as far as going back up to the PowerPoint. Awesome, thank you. We have no financial disclosures. We're not making any money off of this. We do this because we love it. And so our learning objectives, for you guys again is, to really, sometimes we actually need to define what is cancer survivorship, who are cancer survivors, and talk about the epidemiology about it. The phases of survivorship, I think, is important for us to touch upon. And again, we're gonna set the table as far as some of these long-term side effects that we see in survivors, and then what is our approach to cancer survivorship these days. So, and we did talk about this a little bit, Michelle, and for anybody else who did come to our presentation back in February. I opened with this. Maura, who has been my long-time work wife with the survivorship clinic, suggested that I bring this up to kind of start off our presentation about the definition of a survivor, and that different people, that the word survivor has a different connotation to different people. And so, what term do we actually use for somebody who's been diagnosed with cancer? Do you use survivor? Do you use warrior? Do you use thriver? Internationally, it seems, some organizations are using thriver versus survivor. And so it was important for us to kind of lay the groundwork and just get it out there and say, this is what we're calling this particular person who's experienced cancer. We were going with Dr. Rowland's definition. I personally like it myself, is that, anybody who's been diagnosed with cancer from diagnosis through the balance of his or her life as a cancer survivor. And really that's, what we're trying to get at here with long-term survivorship is the balance of life and making sure that their life really is balanced as they move forward. And so as we move forward, you can see, and I think I'm preaching to the choir here, when I think we all know that the number of cancer survivors is just going to continue to grow, which I think is an amazing thing. The idea that we have more people surviving than we did in previous years, and that if we carry out these current projections, in just 6 short years, we could have as many as 20 million cancer survivors living in the country, which is phenomenal. But how are we going to address all of their needs? And so that's where this comes into play as far as, long-term survivorship care. And it's interesting, and I will say for me is I've been doing kind of like a historical review of oncology rehab, kind of like the different milestones that came along that kind of helped define oncology rehab and helped define survivorship. Really, I look back to the Institute of Medicine's landmark publication that came out in 2005. This loss in transition, and this was really a collaborative effort, and the Institute of Medicine was the one that really led the charge on that. And what they found was that there really was no standard of care for survivorship care at that point. And what they found also was that there was insufficient communication between the oncology team and the primary care physician. And so that really led to this definition of loss in transition. The patient goes from active treatment, then all of a sudden, what's next? you know, and who's next, and whose job is it anyway, as far as, you know, being responsible for the long-term care of these survivors, and who's going to address all of those long-term physical and emotional concerns of the survivor as they move forward. You know, they said that you know, there was some surveillance going on, but again, the need for increased communication was really brought up through this document. And also they highlighted that there, you know, there needed to be more research in cancer survivorship. And so, you know, we've definitely have seen a big spike in not just oncology rehab, but survivorship research and literature since that time. And so when we talk about, you know, the kind of the different phases of survivorship, you know, we've heard of the seasons of survivorship. We can also kind of go by this kind of the 3 phases of survivorship. And so the acute phase of survivorship really is more like the initial diagnosis time, you know, for the patient, you know, and really for the person who has just received this cancer diagnosis. It's this initial upheaval that they experience in their life. You know, so this time is really dominated by the diagnostic and therapeutic effects of what's going on, and really trying to save this patient's life. You know, not really thinking about too much of what the long-term ramifications are. That we're really just trying to get through again the diagnosis and getting through all of the medical aspects of the cancer diagnosis. And then as we move through to kind of this extended phase of survivorship, so this is after active treatment, you know, but there's a lot of uncertainty on the behalf of the patient as to really, you know, what's next. You know, what are the outcomes from these particular treatments that they underwent while they were going through, you know, through their cancer treatment. And this is where we really start to see, you know, the concepts of cancer-related fatigue. This is where we're really starting to see the concept of fear of cancer recurrence, and where patients, you know, maybe because they're dealing with the, you know, so much of the immediacy of initial treatment and the diagnosis, that now the severity of everything is really kind of hitting them, you know, and so they're really kind of dealing with this struggle of both the physical and the psychosocial compromises that they might be facing now. As they move past active treatment and try to get reintegrated into life. And it's, you know, for these patients, you know, all of these struggles that were kind of contained within the hospitals and kind of contained within, you know, the oncology clinics is now being, is now much broader, you know, that's being brought out, you know, to home, you know, into the community and to work. And so how do, you know, how do patients deal with that? You know, because now it's in a much different setting. It's, instead of being in that safe zone of being in the hospital setting, now you're kind of really out in the world, and our patients feel a lot more vulnerable because of that. And then as our survivors move into kind of long-term survivorship, so 3 years later, 5 years later, 10 years later, you know, are they still being seen by their oncology team? Have they made this transition to their primary care physician? Is the primary care physician prepared to follow this patient and be able to ask all the questions that need to be asked as far as checking off, you know, cardiovascular health and psychosocial health, sleep hygiene, all these kinds of things that that we know because we're in the world of oncology, but the primary care physician may not necessarily know all of that. And again, for all of us, you know, whether we're PT or we're social work or we're dietitian, you know, to be cognizant of all of these long-term side effects. You know, specifically for those of us in rehab, to be screening for cardiovascular changes, long-term lymphedema changes, radiation fibrosis syndrome. So those are the things that we need to be cued into. You know, and you know, depending also on the age of that person. You know, for our young adult survivors, you know, something that we might see like in long-term survivorship is fertility concerns. So there's a lot that we need to address depending on where our survivor is, in their cancer trajectory. So with that in mind, I'm going to turn it over to Jevin for a few minutes to talk about the tenets of survivorship care, and and who really has a stake in survivorship care at this point.
Thanks so much, Scott. And so I'm going to start by talking about some of the core tenets we think about in survivorship. The first one, harkening back to the Loss in Transition publication, is surveillance. And while that was there, previously, we still focus on that too as a core tenet in survivorship, thinking about not only the person's history of cancer themselves, but also what other cancer screenings do they need, things like colonoscopies or pap smears. And that's all included as part of the review of their survivorship care plan, which I'll briefly mention today and we'll get into in future sessions as well. Also talking about late and long-term effects from treatment. You've heard that thrown around a little bit already, but this is a reality that survivors face after they've completed, whether surgery, chemotherapy, radiation, and so on. We advise on that during the visit and come up with an individualized plan for managing it. But identification is also important too, because sometimes people will be having symptoms and they don't know why they're having those symptoms, whether it's a side effect from the treatment or something else that might be going on. So helping to identify that as a potential reason or as a potential result of the treatment is important. Health promotion as well. So this is an umbrella term thinking about health maintenance and surveillance, thinking about healthy lifestyle behaviors, whether it's smoking cessation or avoiding smoking, limiting alcohol intake, or also thinking about nutrition and exercise as well. And lastly, but certainly not least, coordination of care. People, as Scott mentioned before, tend to fall off the wagon after they're discharged from their primary oncology team, and they don't know where to go from here. And it's a matter of, advising them on who they need to see, whether that might be a referral to another specialist or going back to their primary care team or bringing a concern back to their medical oncology team. And oftentimes I find myself being an advocate for survivors to get the care they need moving forward. And I mentioned to you before the survivorship care plan, and it's a document that outlines the treatment diagnosis and follow-up recommendations. And we give this to people at the time of their visit with us. But is it enough to just hand them this document alone? And the short answer of it is no. The vast majority of survivors find it beneficial to have that face-to-face explanation, not only of the care plan itself, but also the discussion during the visit about their concerns they're having. Because as you can see here, on the slide, there are a number of concerns that go unmet that survivors just don't have discussed at the time of their routine oncology follow-ups. And so that's where we come in, and the survivorship role is its strongest, is addressing these unmet concerns, whether it's quality of life concerns, fear of recurrence, and so on. So let's talk about some of those issues that they have. Thinking about the treatments they've had, for example, with chemotherapy, some of the late effects from that can be things like cardiac dysfunction, peripheral neuropathy, concern over secondary malignancies or sexual dysfunction. With surgery, post-surgical pain or lymphedema, now having cosmetic defects, is that affecting their mental health? Radiation, thinking about, again, lymphedema, radiation fibrosis, as Scott mentioned before. And then there's this circle of potential late effects that falls into all three potential treatment modalities. Fatigue is a common concern we see amongst cancer survivors. Pain, fear of cancer recurrence or anxiety and depression, concerns about supplements and nutrition and weight management, sleep-related issues, deconditioning, and so on. And this is just a breakdown of those side effects, those late effects, and how they can be categorized. Whether it's sleep-related concerns, cognitive difficulties, sexual dysfunction, physical limitations, and so on. And we're going to get into some of these late effects as we go along in these sessions. We're going to talk about fear of cancer recurrence, fatigue. We're We're going to talk about weight management and then also potentially some late effects in one of the latter sessions. But I wanted to highlight here the importance of these in the discussion for a person coming through a survivorship program. Fear of cancer recurrence is certainly up amongst the concerns reported by up to 70% of survivors, and I would argue maybe even more than that in those coming through our clinic. It's definitely the #1 unmet concern, and it can affect a number of different issues they might be having, whether it's nutrition, exercise, and so on. And again, we'll get into that in another session. Fatigue is another very common concern for cancer survivors, and it's experienced in about 80% of those who have gotten chemotherapy or radiation, and it can last up to a year following treatment, but this isn't a hard and fast rule. It's really dependent upon their level of conditioning before, during, and then after treatment and what they've done to help address this. And again, another topic we'll get into a little more as the sessions go along. Exercise and weight management is a prominent concern for survivors, and whether it's inactivity, being overweight, having poor nutrition, and addressing this at the time of the survivorship visit is very important, because oftentimes this, along with fear of recurrence, for example, is not commonly addressed in the follow-up visits with their oncologists or other providers. So it can be beneficial to have this conversation for overall health and fitness, symptom management, and in some cases, reducing risk of recurrence and mortality as well. Peripheral neuropathy is a very common concern among survivors, specifically who have received certain types of chemotherapies. The overall prevalence from the acute phase through the survivorship phase and long-term follow-up can be from 19 to 85, over 85%, again, depending upon the treatment they received, and can lead to permanent symptoms in up to 40% of cancer survivors. So again, it's something that we need to consider as something that can really limit function. Lymphedema, as you all know, is a common concern among survivors as well. And in the Livestrong survey from 2010, of the 14 million survivors screened, 20% included lymphedema as a physical concern. And as you can know, it can lead to things like pain, limited range of motion, and so on. So this, depending on the treatment they've had, whether it's radiation or surgery, can be a consideration for a survivor. Sexual dysfunction is another common concern among survivors, and this can be in both men and women. Men who have maybe had androgen deprivation therapy for a prostate cancer, women, for example, who have had maybe a breast cancer and now are on endocrine therapy, or for those who have had pelvic malignancies and different treatments for that. And again, in that same Livestrong survey, over 3,000 people, it was reported as the 3rd most common concern. And despite this, less than half received medical care for it. And this can be an uncomfortable topic for providers and patients, so it's important to be bringing this up in survivorship care, of course. And last, but certainly not least, secondary malignancies is a concern that survivors have. It's uncommon, but certainly possible, depending on the treatment they've had, whether it's chemotherapy or radiation. And in the cohort of over 2 million survivors surveyed, 8.1% developed a secondary primary cancer as a result of their treatment. And so this is something that, while it might be addressed at the time they were receiving their active treatment as a potential late effect or long-term effect, it's something that needs to be reinforced again, as oftentimes during active treatment, expectations can be missed. So next I want to turn it over to our fearless leader, Tara Samft, who's going to talk to you a little bit about the multidisciplinary approach of survivorship.
Okay, so guys, we've got about 9 minutes left, and I just want to say thanks so much for all of you tuning in. This first session is a lot about getting to know each other, so it took up half the time. And I think I'm just going to explain a little bit about our clinic, and maybe the team could just say a few parting words, and then we'll come back next time and we can share additional details. So I'm Tara Samft. I'm the director of the clinic. I'm a medical oncologist. I'm also board certified in hospice and palliative medicine. And, I came to this team as the director straight out of fellowship, but this team was in existence before I got here. It was established in 2006, and Scott and Maura bring the expertise since the beginning with them. We're fortunate to have had them for 14 years now, and we'll hear more about their experiences throughout the sessions. The way we work is that we all get together once a week, typically. Even now, we do it on Zoom, and we see patients one-on-one. Each patient gets a 30-minute visit with each person. And so it's a 2-hour visit, and they get this personalized care plan at the end, right? So they've had all these counseling tips and referrals, and we give them a survivorship care plan. And so I just thought that was just a very brief overview. As the medical director, you know, I really respect every single person's expertise. Why don't we hear just a bit from Maura and Angela, and then Scott, you can close this out. If everybody can just take a minute and describe what they do, and we'll just save the slides for next time.
Yeah, sure. So I, again, as the physical therapist, you know, I do a lot of different things, you know, screening for range of motion, strength. I can do a home exercise program right on the spot. We can make referrals if need be. And again, it's all about education and really understanding, you know, how to get these survivors moving to be their best possible self. Maura?
Hi, everyone. I'm thrilled to be working with all these physical therapists, because I think nutrition and physical therapy really, our work dovetails each other. And and I haven't yet met a physical therapist I don't like. You know, they're all just wonderful people. I think we're very simpatico in how we approach our patients. So this is very exciting for me. So just so briefly, I'm a board certified oncology dietitian. And registered dietitian. Just so you know, there's a difference between a registered dietitian and a nutritionist. All right, so anyone can call themselves a nutritionist. You know, my cat Puddin is an honorary nutritionist. So I always do that as my public service announcement. And in the work that I do, a lot of it is treating the comorbidities these patients have, you know, prior to their cancer diagnosis, and then also the late effects of the cancer treatment, and also weight management, where a lot of our work, you know, again, dovetails each other. Also, a lot of teasing out supplement use. It's a high use in this population, and also trying to counter all the misinformation that's out there with nutrition, and kind of bringing evidence-based nutrition practice to the patient. So with that being said, I look forward to our next 6 sessions together, and I'll hand off to Angela. Angela looks like she froze. Angela's our social worker, and she covers everything from soup to nuts, I tell you. And we count on her a lot as part of the team. I know oftentimes in my sessions, when issues come up, I have the luxury of saying, you know what, why don't you save that for the social worker? You're going to see her next. So then it allows me to be able to focus on my session. I don't, let's see.
Lost her altogether.
Okay.
She's off altogether.
Can I say something about Angela, since she's not here? And, you know, it's so wonderful having a psychosocial specialist, you know, right there with you. We screen everyone who comes into our clinic for distress. And the reasons for distress can be addressed by any of us. And oftentimes it is because of other physical side effects or that they've experienced. But having the ability to go through, check the late effects, check the side effects, physical side effects, and then, you know, all the existential stuff, the non-physical, non-medical side effects, to have a professional right there who's able to address that has been just such an important part of our multidisciplinary approach. So she's not here to hear it, but she's just a really wonderful person. And she also has expertise in mindfulness-based meaning-centered therapy, and is also an expert in cognitive behavioral therapy for insomnia. So really, you know, just wonderful wealth of knowledge, all of our practitioners, and this is what makes the multidisciplinary approach so special. So we have 3 minutes left. You know, questions, concerns. This tends to be the least fact-packed session, just because we spent some time getting to know each other. So hang in with us. You know, we're gonna hopefully get you the content that you want.
I have a quick question. At what point does the patient get the referral for the survivorship appointment? Is it once all treatment has ended, or do you touch base with them as a interprofessional team earlier on in the course?
So every new breast cancer patient is referred automatically at the new visit. They may or may not process that they've been referred to survivorship. So our Kiki, our coordinator, will call them at some point in their trajectory and just say, hey, this is something that we're offering to you and we'd like to see you when you're done. For other cancer diagnoses, it tends to be after the active treatment is over. And so while we're proud of being comprehensive, I'm not sure that we're, you know, as streamlined in all the other disease types as we'd like to be. And there's room to grow there.
That was a great question, Michelle. Thank you. Does anyone else have any other questions? We have about a minute left with time for maybe one more, since we started a minute late or so, but we understand that if you have to go, you certainly can.
I see Scott Kramer. Are you new to our group?
Scott, I'm going to unmute you here. Okay. Oh, there you go. You got it.
Hi, yeah, I'm new to the group. I'm Scott. I'm from University of Kansas Medical Center or Health System in Kansas City, Kansas.
Hey, Scott.
Yeah, it's good. It's good to see you, Scott. I was getting worried that I didn't see you pop up. So we,
there's a time zone issue.
Yeah, I was afraid that might have been the case. So yeah, we start 3 p.m. East Coast time. So
Gotcha.
I'm sorry that we didn't communicate that to you.
My time was off from the other night or the other day when we met. It was at 3 o'clock, so I must have messed it up. I'm sorry, guys.
No, that's okay. Well,
That's
listen.
okay.
So this session was recorded. We're going to record all the sessions. And Scott, you know, you and I can connect afterwards if need be. And yeah, we will. We're gonna, you know, as we go through these next 5 sessions, we're gonna get into how do we get referrals? How do we get funding? You know, that's going to be the next session. We're really going to get into that. You know, and then we're going to go into fear of recurrence, cancer-related fatigue, and weight management in sessions 3, 4, 5, and then we're leaving the last session as kind of like a wild card for you guys. So if there's anything specifically that you want to address in our last session, you know, we want to hear from you, because again, you guys are the ones that make this wheel strong as the spokes. So, you know, we want to be able to support you guys however we can. But I know that it is, it's 4 o'clock East Coast time. So to be mindful of everybody's time, I think we'll sign off for now, and we'll be back in 2 weeks for our next session. If you have any questions, please feel free to reach out to Jevin or reach out to me. You know, we welcome your feedback. We need your feedback so we know how to make this better. And in the meantime, everybody, please be safe. Take care of yourselves. We'll see you back here in 2 weeks. All right.
Bye-bye.
Bye.
All right, guys.
Everybody,
Thank you.
for
Thank you
coming.
so much.
Take care.
Scott, you want to stay on for a second?
Oh, sure, yeah.
I'm gonna take off.
Yeah, you can take off more.
Thanks.
Take care.
So,
I'll leave the meeting too. Unless
Okay.
Scott, did you have any questions for me or?
no, I guess you can stop the recording now. I think we're good.
Okay.